It can also cause unexplained falls, generally just feeling weak, kind of feeling fatigue or even sleepy. And then there's the so-called coat hanger pain, which is pain that kind of covers the neck and the upper shoulders, kind of this dull pain that can actually be caused by low blood pressure. Blurring of vision can occur, and also thinking changes or cognitive changes, feeling kind of slow and kind of brain fog. And so these things can kind of come on in episodes and are an indicator that it may actually be the blood pressure that's causing some of these symptoms. Orthostatic hypotension, or this low blood pressure, is very common in Parkinson's disease, with up to 40 to 60% of patients experiencing it. Now, as we'll talk about, it can be caused by Parkinson's itself, but the medications that we use to treat Parkinson's, if you look at the side effect profile for all of them, they will list low blood pressure or hypotension. Common triggers, or things that can make it worse or bring on this low blood pressure state, are quick changes in position, so jumping up out of bed in the morning, exercise actually, dehydration, and I put this in red and bolded it because even people without Parkinson's disease can develop orthostatic hypotension if they are dehydrated. So basically, if your tank isn't full, you can develop these symptoms. So you can imagine if you have Parkinson's and you have this orthostatic hypotension already, and then you add some dehydration to it, it can really make symptoms quite severe. Eating, surprisingly, can also make this worse because blood is then drawn to the gut, especially after a big meal, and basically diverted away from the brain, and this can be a trigger. Similarly, being in a hot environment, being outside in hot weather, or taking a hot bath or shower or sauna or anything like that, then again diverts blood away to other parts of the body and then away from the brain. And then alcohol can also be a trigger. So why does this orthostatic hypotension occur? Well, it's kind of the normal response to what happens when we stand up is if you imagine us as a tube of water. When we're laying flat, that tube has water that fills the whole tube, but then if you turn it upright, all of the water will go down with gravity. So that's exactly what our blood does when we stand up. It kind of pools into the lower half of our body, into these veins, which are quite expandable. And that fluid shift will then in turn cause less blood flow to go to the heart, which then in turn lowers blood pressure. So our body has a compensation for this, and what will happen is that there are special sensors in the arteries that detect this lower blood pressure and then respond by signaling to the rest of the body, particularly the heart and the blood vessels, to make the heart pump faster, and then also to constrict or clamp down on the blood vessels so that it increases the pressure. Now this happens automatically. It's an autopilot, and you don't have to think about it. Our nervous system does this on its own. So that messenger that is helping give the signal from those arteries to the heart and the rest of the veins in the body is called norepinephrine, and it's a neurotransmitter or a hormone that helps kind of transmit this signal. But we know that in patients with Parkinson's, there's a reduction of this neurotransmitter, norepinephrine, and so that is part of the reason why orthostatic hypotension is so common. In addition, the heart is actually changed in people with Parkinson's, and it doesn't receive that signal as well. So that is basically the underlying reason why dizziness and lightheadedness occurs, is because this low blood pressure state remains instead of recovering. So ways to kind of test for orthostatic hypotension is we can do this in clinic by getting what we call orthostatic vitals, and it's taking your blood pressure and heart rate in different positions. But you can also do this at home, and it's something that we recommend quite frequently, is taking your blood pressure when you've been in a seated position for at least 5 minutes, and then stand up and repeat your blood pressure again after you've been standing for about 3 minutes, and recording the differences between these two blood pressures. So what we define orthostatic hypotension is the top number, or the systolic number, is a change in 20 points, or the bottom number, the diastolic blood pressure, a change in 10 points. So if someone is sitting and their blood pressure is 145/80, that actually sounds like they have high blood pressure, and one might not suspect that they would be suffering from low blood pressure issues. But if you actually stand up and then record the blood pressure, it does drop to 25/70, and that is orthostatic hypotension. So ways to combat this low blood pressure state are obviously changing position slowly, kind of doing that, kind of priming the body, ready to get to stand up out of bed, letting yourself equilibrate, letting all the fluids kind of remain to the steady state to the brain. That can help combat this some. Also, increasing the volume of the blood and the volume in our venous system is another way to do that, and increasing salt and fluids. So you won't often hear a doctor saying to increase salt, but these are one of the rare cases where it's helpful to do that. And then always kind of having your water bottle with you and refilling it throughout the day is very important. Increasing or raising the head of the bed can also be helpful. So about 4 to 6 inches, or about 30 degrees. And there's devices that are sold, different mattress or things that you can put under the actual bed frame. Or you can just simply get a 2x4, enough to increase the head of the bed, basically getting the heart below the brain so that there is less signaling to the kidneys overnight that we need to get rid of this extra fluid, and can, one, help you decrease going to the bathroom at night, but then also hopefully have you have a higher blood pressure in the morning so that the tanks are kind of more full. If physical activity seems to exacerbate the blood pressure issues, sometimes we recommend doing recumbent exercises, so a stationary bike or a rowing machine, or actually swimming in a pool, so that you can still get the important exercise in without passing out. It's also very important to be very careful when you have been exposed to heat, or if you have a fever, or if you've been in a hot shower. So things that you do after those activities, like eating or standing for a long time or exercising, you may want to avoid until you've kind of made sure that you're rehydrated and that your temperature is back to a normal state. You can also, especially when sitting for long periods of time, doing these counter maneuvers. So if you've, in 20 minutes when you get up and walk around and go to the bathroom, and you may want to, in the next 5 minutes before you need to get up, start doing some of these maneuvers and clenching the muscles in the legs and the buttocks and the thighs, and then also uncrossing and crossing the legs, basically using your muscles as little pumps to push the fluid back up to the brain. And then compression devices. So really wearing the stockings are often difficult. You sometimes may need help to get them on, and you really need to wear them all the way up to the waist and into the abdomen for them to really be helpful. So what we're now recommending is an abdominal binder, so something you can easily put on throughout the day and take off if you don't need it, and wear it as needed. Something that you can get at any pharmacy or online. But that kind of pressure on the belly or the abdomen can help increase the pressure and then bring it back to the brain. Before an activity that you know will exacerbate the low blood pressure, you can drink a couple of really tall glasses of cold water, and that can also help combat this. And then very importantly, and I'll mention it last, is to talk to your doctor about medications that have side effects of lowering blood pressure, as well as medications that you're on that the goal is to lower blood pressure, because those may be able to be reduced or stopped at this point if this is a significant issue. There are also medications that we have to treat orthostatic hypotension, and they're listed here. I'm going to mention the last one that I have listed a little bit. It's the only FDA-approved medication, so it's the only one that has been studied and approved by the FDA to treat this particular issue. It's called droxidopa, or Northera is the company name. So this is a unique molecule because that droxidopa actually gets converted into norepinephrine in the body. So as I mentioned earlier, that's the chemical or the neurotransmitter that's important for helping increase the blood pressure by constricting the blood vessels and making the heart pump faster. So these medications, you'll have to talk to your doctor about them, but one thing that I would like to mention is just that we need to always monitor for a high blood pressure when you're laying at night to make sure that these medications aren't kind of overshooting their goals and you're developing high blood pressure when laying down. So I'm going to switch gears here now and talk about the sleep disturbance that can happen in Parkinson's disease. So sleep issues are very common in Parkinson's disease, and actually sleep changes are part of the normal aging process. As we age, you may need less sleep. The issues that people with Parkinson's encounter, in particular with sleep, are waking up frequently at night and difficulty getting back to sleep, daytime sleepiness with an increased need for naps during the day, restless legs or leg movements or involuntary jerking of the extremities, vivid dreams or nightmares, and then lastly, this dream enactment or rapid eye movement sleep behavior disorder, which Dr. Murman mentioned earlier, and we'll talk a little bit about that. So REM sleep behavior disorder, or RBD as it's called for short, the first thing you need to understand about what REM sleep is that there's different stages of sleep, and during REM sleep, the reason that it gets its name is rapid eye movement, is that when you are in this stage of sleep, the eyes are actually flickering back and forth at a very quick rate. And so when we study people in labs and look at their sleep state, we're able to actually see this. So what happens during REM sleep is that we dream. And then at the same time, our body kind of shuts down most of the muscles in our body, except for our eye movements and our breathing muscles. We can't really move. And so when we're dreaming, we're not acting out or doing the things that we're dreaming about. But in somebody with RBD, this mechanism is broken down, and instead, the dreams are act out. So it can be violent or very active, so there can, as you can imagine, there can be thrashing around, punching, kicking. And somebody who is in REM sleep does not remember it, so you can imagine somebody with RBD may hurt themselves or somebody that they're sleeping with because they have no memory of what they're doing, and they're in a deep sleep and are moving around. It's interesting that this RBD is something that can actually predate the Parkinson's disease diagnosis for years and sometimes even a decade or longer. So it's something that we're looking at as a marker for potentially diagnosing Parkinson's disease early. There are treatments for RBD. First of all, just making sure the person is safe by putting padded rails up or padding around the bed or moving the bed to a lower location. Or there are medications such as melatonin or clonazepam or Klonopin that we often use that can be pretty good at controlling these symptoms. Going back to the sleep disturbance in Parkinson's disease, there are many reasons why sleep disturbances could happen. Frequent urination, that's quite common in Parkinson's disease, the uncomfortable stiffness and cramping. You're less often taking medications overnight, so the medications are wearing off and can just create kind of uncomfortable sleep and wake you up. Also, untreated or unrecognized depression and anxiety can really affect sleep and should be addressed before any other treatments are undergone. I also want to just mention here, sleep apnea is a very common issue, and so can cause snoring and disrupted breathing, but then also can lead to sleepiness and poor sleep and disrupted sleep, and should really be screened for if this is something that's going on. There are other measures that we can take that are non-medicines that are just as important and should always kind of be thought about as the first step in treating sleep disorders, and that's proper sleep hygiene. So this term is something that a lot of sleep specialists talk about. So making sure that there's a regimented schedule with sleep, making sure that you're not sleeping during the day, that you're not taking activating medications later in the day. One that we commonly use in Parkinson's is selegiline, which can be very activating, and so we recommend to take it earlier in the day and no later than the afternoon. Also, caffeine, when taken later in the day, can cause a significant insomnia. And then alcohol, I'll mention here, is that it can make you sleepy, but then it's known that later on in the night it can fragment sleep, so sustaining from these can really help with sleep. Now, I also mentioned decreasing fluids prior to bed to then help you decrease the amount of trips to the bathroom. which goes against what I'm saying earlier about orthostatic hypotension, about the need to stay hydrated. So some of these symptoms do kind of need to be balanced if they're going on concurrently. Also, making the bedroom as comfortable as possible, making it quiet, dark, cool place. And this is a big one, avoiding screens, because that light is a signal to the brain to stay awake, stay awake. So if the last hour before you're going to bed, you're on your phone or your iPad or watching TV, or if a TV is just always on in the bedroom, those are things to get rid of to really kind of help with sleep patterns. Getting regular exercise is important, but not doing it too late in the day, as it can be quite activating. And then if you're lying awake for an extended amount of time, getting up and doing something else, so that the brain equates laying in bed with sleeping instead of staring at the ceiling. Sleep disturbances really should be addressed as the things I have talked about before we talk about starting to use medications. But there are medications available, and one that I always recommend as a first line is melatonin. And this is actually a hormone that you make in the brain naturally. We all make it, and it is secreted in response to day-night cycle. So when it's dark out, melatonin is secreted. And so this is something that it can be bought over the counter and is relatively safe and non-habit forming. And usually start people on a couple of milligrams a night, and then can gradually increase over time. There are other sleep aid medications. I won't mention them here, but to be cautious, especially in something like Ambien type of medication, which can be very habit forming and are really only used for kind of a short-term aid. The last few minutes I'm going to talk about drooling a little bit. And so drooling can be very bothersome, and so it can range from embarrassing difficulties with having the saliva fall out of the mouth, to more severe issues with swallowing that then can lead to what we call aspiration pneumonia, which is when the saliva actually goes down into our windpipe and then into the lungs and sets up and can cause a bacterial infection, which is a pneumonia. So not only is it embarrassing and annoying to deal with, it can also have health consequences. So in Parkinson's, there's a thought that it is due to kind of what we call poor clearance. So that saliva pools up because you're swallowing less frequently, or your swallowing isn't quite as smooth as it had been in the past. But also, there may also be an increased production of saliva. The head and the neck positioning may also help with this. Drooling or the saliva coming out of the mouth, because sometimes in Parkinson's we tend to be a little bit more flex forward, and then also the mouth tends to be open a little bit more, and so that just physical effect can cause drooling. It also can be more common during an off period, so adjusting medications can be a way to address that. So the symptoms can be as mild as, creating a wet spot on your pillow at night, to the embarrassing excessive saliva then that can interrupt speech and talking and swallowing. And some of these issues, if severe, should be evaluated by a speech-language pathologist or a speech therapist to ensure that there's not a risk for this aspiration, and also to kind of develop some ways to help cue with swallowing so that it's something that doesn't get worse. It's fairly common in Parkinson's disease, with anywhere from 10 to 84% of Parkinson's, depending on which literature you look at, reporting issues with drooling. Known to be more common as people age, and also as the disease progresses and becomes more severe. Males have a higher risk of having it, as well as if there are hallucinations going on. Treatments that we can undertake to treat drooling are, first of all, identifying medications that could be exacerbating it or causing it. So some of those that were mentioned earlier into treating the cognitive issues and the hallucinations would be donepezil and galantamine and quetiapine. But you definitely would want to discuss that with your neurologist or your practitioner, because these may be something that you need to continue. It's just kind of weighing the side effects if they're happening. Some non-medication options include chewing gum and sucking on hard candies, kind of helping trigger that swallowing technique. And then what I mentioned earlier is seeing a speech therapist. There are oral medications that can be tried. Glycopyrrolate, which is an oral medication or a pill that we can take. It has the risk of causing some confusion, so it has side effects. It's not without its side effects. And then atropine drops, which are actually eye drops that we have people place under the tongue, tend to have less side effects, but always have the possibility to cause confusion. And then medication like clonidine, which lowers blood pressure, which again is side effects. So something I just wanted to mention really briefly is Botox injections. I know Dr. Torres is going to be talking about injections later, but we can do these injections actually for excessive saliva. And so what we do is we center or do an injection into the parotid gland, and there's a couple of other glands that are also involved. But the parotid gland makes the bulk of the saliva. And so by actually putting or doing an injection of the toxin into that gland can actually reduce the amount of saliva that is produced, and that lasts for 3 months or sometimes even longer for people. So that can be a relatively side effect free, other than the pain of the injection, treatment for this really bothersome symptom. So I just wanted to conclude today to kind of recap. Dizziness is commonly caused by low blood pressure, and there are ways to kind of identify triggers and treatments. Sleep disturbances are also another common issue, and there are many things to think about to address if there's sleep issues. And then lastly, drooling can be very bothersome and also have health consequences. And Botox injections are a relatively safe alternative, or a safe alternative to medications for treating drooling. All right, thank you.
My own. We're going to do our first question and answer session with the first three speakers. So if Dr. Bertoni, Dr. Murman and Mara, you can just stay right here. These are the cards that are on your table, and if you will, you've probably jotted down questions already. There's going to be Nebraska Medicine staff that's going to be walking around collecting these. Just hold up your hand, and they will come and get the card for you, and then we'll ask the questions. And again, we'll try to get through as many of them as we can. And following this question and answer session, we will have a break, and you can visit the vendor tables, and I encourage you to do so in the atrium. And also, again, the bathrooms are to the left in the atrium. Also, I want to remind you that on our website, the booklet that you have today with all of the slides, etc., will be on our website at the University of Nebraska Medical Center, so don't worry about getting extra copies with that. One more thing, hashtag PD Conference 2019 for any social media. We'd really appreciate that. And last but not least, the internet connections would be LV, as in Victor, CC. It stands for La Vista Conference Center. Then the number's 19, and then the password is 1234. The first question is for Dr. Murman. Please explain Nuplazid as advertised on TV.
So Nuplazid is our latest edition of medication used to treat hallucinations in Parkinson's disease. And right now, that's the FDA approval. Those two things, you have to have Parkinson's disease and visual hallucinations. It has a unique mechanism. Traditionally, we've used some medications off-label. They're used in other situations, but we use it in Parkinson's patients with hallucinations. They blocked dopamine. So there's some antipsychotic medications. Some of the original ones were drugs like Haldol or haloperidol. There's a new generation, and one that we do use is called quetiapine or Seroquel. So they block dopamine, but it's a catch-22 because they're blocking dopamine, which we're trying to increase to help you move better. So one of the challenges treating hallucinations in Parkinson's patients with our older medicines is we always run the risk that we make people worse from a motor standpoint or movement standpoint. So Nuplazid works in a different neurotransmitter system and doesn't worsen the Parkinson's features. Right now, it's new. It has to kind of be prescribed through a central pharmacy. So with your provider, you can't just go to your local pharmacy and get it. And it still is quite expensive, to be honest, so you have to kind of work with their patient assistance program to potentially go on it. But it would be for somebody that has Parkinson's, having problematic visual hallucinations. So if the hallucinations aren't bothering you, it's not worth going down that road. But if you're scared, tormented by things you're seeing, if it's causing problems in your everyday activity for you or your caregiver for your family, then it'd be something to definitely talk about.
Thank you. Next question will be for Dr. Bertoni. Do you recommend genetic testing to confirm diagnosis?
Well, that's a good question. As I talked about earlier, there are genes. It depends on the situation. We still treat everyone with Parkinson's disease, regardless of their genetic makeup, with the same medicines. So if you're getting benefit from your medicines, it's not necessary. However, if you're interested in being in a trial or interested in being in some sort of a database, let's say through the Nebraska Parkinson's Disease Registry, you can let us know. And some people are just interested there's things called 23andMe that are just not the same. You want to get a reputable place that you get genetic testing. So it depends on the situation. I don't think it's necessary. I don't know, any other comments here on that? If you want to know, that's one thing, and then you can attend group sessions for LARC2 or some other form of genetic disorder. If there's somebody in your family that has a known genetic disorder, you might want to know that. But otherwise, it's not for every person with Parkinson's disease situation, all right?
Dr. Murman, is there a specific cognitive assessment you recommend to tease out the early deficits, MCI versus dementia? MCI is mild cognitive impairment. Has there been any research to show slowed decline or even benefits in cognitive function with therapy? For example, speech language pathologist or occupational therapist?
So the first part, which tests are best, there are a couple office-based memory screening tests that are widely used. Traditionally, we used one called the Mini Mental State Exam, or MMSE, but there's a newer one called the Montreal Cognitive Assessment, which is quite good at picking up early changes. It captures a lot of different aspects of thinking, so that would probably be the best test for a provider. Now, sometimes in primary care, they'll do a very quick screener. They might just have you draw a clock and try to remember 3 words. You would want to do a little bit more than that. So this MoCA, Montreal Cognitive Assessment, probably takes about 10 minutes, 15 max, and that would be a useful screener. The gold standard is going to be a formal neuropsychological assessment. So if things are mild, atypical, not clear, then honestly we would refer you to neuropsychology to do probably a morning, probably an hour and a half worth of testing plus an interview. So spend a morning with the neuropsychologist, and they would much better be able to tease out, is this normal or not? Because they would compare your scores to people with your same education and age to get a better idea, okay, is that really a problem or not? The second question, clearly the pharmaceutical medicines we use to help memory have not been shown to slow progression. They help symptoms, so they can help you focus and remember. When you stop taking them, they stop working. They don't slow down Parkinson's disease. And we're still at the early stages. I think there's growing evidence and desire to have some specific cognitive activities, which exercises on the memory and thinking side are best. And we don't have that yet, but there is a growing movement to have people like speech pathologists kind of do cognitive rehab, much like you go to delay the disease or go to a big or loud program to help with physical activity or volume of your voice. I think we're in the early stages to maybe have some classes that would focus on the memory and thinking point. To be honest, we haven't proven that that can slow down the disease, but it certainly can help with function and thinking.
Thank you. The next question, Dr. Seier. Excessive sweating, does medication or Parkinson's disease cause this? Back and hair get soaked with sweat.
Yeah, so excessive sweating is a known, it wasn't on my iceberg analogy, but it is a known non-motor symptom in Parkinson's disease that can be quite bothersome. some things to think about are medications that could exacerbate it or cause that. So some of the SSRI or SNRI medications have been known to cause excessive sweating, but it is definitely a non-motor symptom in Parkinson's disease. Another thing to think about is the timing of the Parkinson's disease medications. There may be a timing issue there of when the medicine, your carbidopa, levodopa, or your Sinemet is wearing off, that then could be a trigger, or it could be a sign that that's an off symptom, or those fluctuations in the medicine levels that's causing the excessive sweating.
One more, Dr. Seier. What option would be considered first for drooling, and how do you decide what to try first?
Well, so I mean, it would be really up to patient preference. So it would be how severe the drooling is. So sometimes doing things like sucking on hard candies and chewing gum are adequate. But often I will try the atropine drops as a next step if people are willing to do that. But honestly, if it's an excessive issue where we're concerned about the physical manifestations, like making it really difficult to swallow or speak, or we're talking about the concern for aspiration pneumonia, I think Botox really is the way to go, because it can be a treatment that you get once every 3 months and can really kind of take care of the problem.
Dr. Murman, if hallucinations are caused by a medication, for example, entactapone or rasagiline, can they be overcome by discontinuing the medication? If so,